Acoustic neuroma is a benign tumor that arises from the covering of the balance nerve. The name is terrible because it implies a tumor of the hearing nerve, but really it's a tumor of the balance nerve. More appropriately, it should be termed vestibular schwannoma. These tumors arise from the balance nerve that connects the inner ear to the brainstem. So the function of these balance nerves is to convey acceleration data, angular and linear acceleration data of the head, and impart that and get that message back to the brain. What can happen sometimes is the Schwann cell covering of those nerves can start growing faster than all the other cells around it. The cause for these tumors is really unknown. As these tumors grow within the internal canal, they can affect the balance nerve directly. They can affect the cochlear nerve, the hearing nerve, and affect hearing and cause tinnitus. And they can also push the facial nerve aside. Usually, the facial nerve is quite resilient, and facial paresis and paralysis is uncommon at presentation. Some of these tumors grow slowly, and others can grow fast. Typically, an acoustic neuroma will grow anywhere from 1 to 10 millimeters per year. The cystic variety can grow much faster and grow 25 to 35 millimeters per year. It is very important to ascertain when you have an acoustic neuroma whether we're dealing with a solid tumor or a cystic tumor. These tumors can also be confined to the internal auditory canal, or they can be confined to the nerves that connect that inner ear to the brain. And these tumors can become quite voluminous and expand the posterior fossa, cause significant displacement of the cerebellum. Typical symptoms that arouse suspicion for these tumors include tinnitus in one ear, sensory or neural hearing loss in one ear, disequilibrium, vertigo, and ataxia. Other symptoms include headaches. When diagnosed with an acoustic neuroma, there are 3 management options. One is to follow and watch the tumor over a period of time. If the patient has a small tumor, these can be reasonably followed with serial MRI imaging. So what we're talking about here is doing MRI scans every 6 months and looking to see what the growth rate is of that tumor. Many tumors will not grow and do not cause any significant dysfunction. We are of the belief that these patients do not require surgery and do not require any radiation treatment. Other treatment options include radiation therapy and microsurgery. Let me discuss radiation therapy for just a minute. Radiation can be given to the tumor in a number of different ways: gamma knife, cyber knife, and LINAC. These are all attempts at concentrating radiation treatment to the core of the tumor. The tumor is not radiation sensitive, but what radiation really does is induces scar tissue around the tumor and between the tumor cells. The downside of getting radiation therapy is that scar tissue can develop between the tumor and the facial nerve, where scar tissue was not present previously. This can become problematic if the tumor begins to grow after radiation therapy and surgical excision is warranted. Microsurgery can also be offered to treat these tumors. There are 3 different ways of approaching a tumor like this. One approach involves the middle fossa approach. This involves an incision from the front part of the ear and up the scalp. These procedures are all done by me, a neurotologist, and my neurosurgeon. This procedure involves a craniotomy with removal of some of the bone over the brain and an approach to this internal auditory canal from under the brain. The brain is not exposed, and the procedure is done extradurally, meaning The procedure is done outside of the tough covering that protects the brain. This is a delicate procedure that requires a skilled surgeon with a great deal of experience. The tumor is then excised or removed from the facial nerve and the hearing nerve. Another approach to saving the hearing involves the suboccipital approach. This approach involves an incision further back behind the ear with removal of some of the bone over the cerebellum. This is an approach to the posterior aspect of the temporal bone. This involves removing the tumor from the hearing and the facial nerves. In our website, you can find more information about these approaches. Another approach is the translabyrinthine approach. When the patient has lost hearing and has a sizable tumor, the translabyrinthine approach can be used. This involves an incision behind the ear, removal of the mastoid bone, and traveling through the labyrinth, as the name implies, translabyrinthine, to get to the tumor. And again, the tumor is then dissected and resected off of the facial nerve.